Okay, great to be here today. Just a little background on myself. I've actually been collaborating with the dorm for almost 4 years now, and really been a great experience for me in terms of evolving the way that I approach patients, as the title of the presentation says, beyond medication. So I'm classically trained pharmacologist, and over the past maybe 3 or 4 years, I've really started to look for additional answers, trying to get away from the heavy medication burden that a lot of the patients come to us on, and looking at other lifestyle interventions and nutritional interventions in ways that we can kind of shift the focus, a little more off the disease and more towards a wellness model. Next slide. So here's our agenda. I'm going to speak a little bit about what integrative psychiatry is, with the caveat that this is not an exhaustive lecture on integrative psychiatry. I've done some additional training, which was essentially a year fellowship. I'd like to think of this more of an overview and an approach. I'm not going to present everything in integrative psychiatry here. There's no way you can do that in 1 hour. But I think it's useful to show some of the principles that we use, the general approach, and how we use lifestyle interventions, and how we work as a team to really do what's best for our patients. So we'll speak a little bit about what integrative psychiatry is, how we're going to approach young adults from this perspective. And then I think probably the most interesting part will be case studies, how we actually apply these principles to some of the clients that we're seeing, and how we can achieve better long-term outcomes. And then we'll, as Amanda said, we'll have some time for questions and answers. Okay, so the first section, we'll talk a little bit about what integrative psychiatry is. And as I said, I had been doing classic psychopharmacology pretty much solely for about 15 years. Really was not always happy with the outcomes, patients not always happy with the outcomes or the side effects. As we all know, a lot of these medications have pretty significant side effects. A lot of patients don't like being treated as an illness. They think that the focus has kind of been taken off them as a person. So this approach, I think, is very nice because it integrates, as the name integrative psychiatry. This is not only nutritional, non-traditional medicine, but it integrates the best of both. So it takes conventional treatments such as pharmacology and integrates complementary therapies. We use laboratory analysis to look at mainly nutritional deficiencies, but also the field of pharmacogenetics is blossoming. There is some evidence about infections, toxicities, and even food allergies that we can approach that sometimes could be helpful to get better results. Next slide, please. So our goal here, and I think this works very well with the dorm model, is individualized treatment. So I come from the world of academic inpatient medicine. It's pretty much what's the symptoms, make a diagnosis, here's some medication, what's your outpatient plan, and then see ya. So here we're really working with the patient to develop something tailored to them and how they're going to live life beyond acute care. So we do a few other things, their overall functioning, nutritional status, but the main thing, since we're actually seeing people in real life, not in a confined setting, we're focused on lifestyle. So how do people eat? How do they sleep? Exercise? Very things that we think of maybe as basic, but really can be essential to long-term good health. Certainly, we want to avoid non-prescribed mood-altering substances, and Dorm has an abstinence-based model, which also integrates very well with this approach. And not to overlook physical illness. We do have a lot of patients with comorbid physical conditions. We do a lot of referrals to primary care. We do a lot of referrals to specialists, because you never really want to underestimate the effects that physical illnesses or deficits can have on someone's overall mental health. Next slide. Okay, so I think, at least in this setting, we're all pretty much aware of the MindBody Connection. We all know that to have a sound mind, you need to have a healthy body, and and vice versa. So there are a variety of mind-body practices that clients at the dorm are able to avail themselves of. Certainly there's Reiki, meditation, yoga, acupuncture, and certainly there's a lot of evidence, Eastern medicine for acupuncture working, and yoga is becoming more and more popular. A lot of you are probably familiar with mindfulness meditation you may already be doing with your clients. Next slide. Okay, so how are we going to approach symptom reduction? And just a little bit more, this is a holistic approach that really encompasses the entirety of the patient, certainly physical, mind, spirit, emotions, social and environmental factors. And one thing I wanted to add here is there is a focus on people's living environment here. A lot of dorm clients are in sort of residential housing, and this is very important. In order to maximize ability to recover, you also need to be in a healthy environment, an environment where you can have camaraderie, where you can have support. People are at different levels of recovery, and we really shouldn't underestimate the value of that in having our patients recover. So we're considering our patients interdependent parts, but everything needs to be in balance. We're not focused on them as a disease. The interesting thing is clients are always at different levels of recovery. Some people are much more quote unquote well than others. Some people have just gotten out of a hospital. Some have been out for months or even longer. So we really need to meet them where they're at. And part of that is that not everybody wants this approach, a holistic approach. Some people just want medication. Maybe that's all they know. Some people don't really know what they want. They just want more information. So, the key thing that I'm able to do with patients is you need to be flexible. You don't get into battles with patients. You try and work with them to get them where they want to ultimately be. So you have to be flexible is key, and availability is key. So if you're working along with a client and they reach out to you, or a team reaches out to you, and you take days to respond, I mean, it's really not acceptable for this model. I mean, I tend to respond within hours or less, for better or worse. I mean, generally for better, but you really want the patient to feel that you're kind of a partner with them in their recovery journey. Next slide. Okay, so this is a little bit of an unfamiliar role for doctors. Doctors, we're used to leading teams, and here you're part of the team, and everyone is really an integral part of that team. Clients will have a therapist, a coach, a dietitian, a yoga instructor, a personal trainer, someone who runs their housing. So everyone is on this team. Really need to take a little bit of a back seat, and my role, I kind of feel like I'm just really working to get patient to a place where they can utilize the larger treatment program. Certainly some people need more medication or other interventions than others, but for a lot of people, once you get them somewhat stabilized, you really just want to get them to that point where they can participate in their therapeutic program and kind of reintegrate into their communities. And the other important part about this is communication is key. You really need to be in touch with someone's therapist or coach. We have regular team meetings. We have unlimited texting, email. Sometimes it involves, we've had instances where a patient may be somewhat unreceptive to interventions coming from the physician, who may be a more threatening person to a lot of patients, and we would have maybe a joint therapist MD meeting. I've done family meetings along with clients and therapists. So you really, getting back to the other principle, you really need to be flexible and try and figure out what's needed in a given situation. Next slide. Okay, so here's where the initial evaluation, which for some people this may be more of what they do than others, but certainly the standard evaluation: what are the symptoms, make a diagnosis, substance use history, and probably after that is where the bulk of classical psychiatry has begun and ended. But at this interview, I'm also finding, everyone has a nutritional assessment, but I'm also asking about what their nutrition and eating habits are, what their current physical routine may be, exercise regimen, how do they sleep? Are they up all hours on their phone, absorbing blue light when they're trying to sleep? What's their family structure like? Who are they, in relationships with? What kind of supports they have? And, certainly very importantly, what current mechanisms they have to manage stress. Some people have, great coping skills. They exercise, they meditate. Some people have absolutely no skills. And, this is something that's going to be built by the team, but we really need to know where we're starting from. I always look for what can we potentially treat. And, probably the most important thing that I'm going to do at an initial assessment, a lot of patients are coming from different treatment programs or several runs of treatment, some successful, some not. Some have accumulated lots of medicines over time. And where can we look to limit the overall medication / side effect burden? How can we streamline things? How can we alleviate unnecessary polypharmacy when it presents? Next slide. And here are some of our basic lab tests. A lot of you are probably using these already. Certainly basic metabolic panel, CBC, magnesium, zinc, copper. Low zinc to copper can be associated with depression, anxiety, even attention deficit. A lot of our patients are on atypical antipsychotics with a very large metabolic burden. So what does their lipid panel look like? What is their hemoglobin A1C, which is a measure of 3-month blood sugar? What does that look like? Next slide. And another important point of integrative psychiatry, we're looking at values that are optimal, not necessarily normal. So normal levels for, say for vitamin D might be 30 as good, but I'm looking for 40 to 60, for depression. B12, especially I believe the cutoff is about 180 on a Quest lab. Patients with depression, we really want more like 500. So there's definitely a distinction between, patients will say, I had my labs, they're all normal. I want to see the labs. Sometimes we reorder them if necessary. Thyroid's another incidence. Sometimes you want to, patients with normal thyroid, we really want patients with mood disorders much towards the upper quartile as opposed to barely normal. HSCRP is actually a measure of inflammation, and there's some evidence that patients with high inflammations might respond better to certain antidepressants that have some dopaminergic effects as opposed to just a standard SSRI. So these, this is just kind of an overview of some of the tests that we order. Next slide. Okay, so genetic screening is a very hot thing. A lot of people order genetic screens. A lot of patients will say, I got a genetic screen, my doctor said I should be on this medication. So, if only it were that simple. This is really a tool. It's not like a step-by-step recipe for success. This test is a lot. I personally use Genomine, but there's also GeneSight and a variety of other products that are equally good. Tells us the effects that medicine will have on your body and how also pharmacokinetic, how your body will actually metabolize certain medications. People don't all metabolize medicines at the same speed, and this can really have significant implications for dosing. Next slide. And so the screen just shows various, gene, what we call alleles at different variants. I do find the test helpful. I don't always order this straight away. I often order it in people who've had significant side effects or have quote unquote failed multiple medications. Can provide some useful guidance about where to head in terms of your next choice. Next slide. This is probably one of the most important tests on there, I feel, is the folate metabolism. This is also kind of a hot topic now. So a lot of our patients with mood disorders or ADHD do have deficiencies in this particular enzyme, and without methylfolate, which is actually the active folate, you actually have a very hard time producing serotonin or norepinephrine or dopamine. So you can really continue to, give medicine after medicine. You may not get the same response you would otherwise. So, there are studies showing that supplementation of activated folate can make antidepressants work better. There's even some evidence that some people with methylfolate alone can improve in terms of depression and anxiety. Anecdotally, I also find this to be a very unthreatening way for patients to approach integrative medicine. This is unfamiliar to them, and if you're prescribing sort of a vitamin supplement, even if people are sort of shy about taking new meds or other meds because they failed many, a lot of patients will actually be receptive to this intervention. Next slide. This is really just to illustrate folate metabolism, and it's all the way down at the bottom where you get methylfolate. So a lot of times you'll try and get this approved, and the insurance company says, well, this is no different than folic acid. Well, it is, because you have to go through all these steps to get to activated folate. And you can see all the way near the bottom, if someone has an issue with that genetic mutation, they're not really going to produce methylfolate the same as if you just sort of bypass this entire machinery and just supplemented with it directly. Next slide. And just to go through some commonly used supplements before we get to some of the cases, I use a lot of lithium orotate, and lithium is lithium, but not really. So lithium orotate is really what we call nutritional lithium or microdoses. There's a lot of studies from around the world, places where lithium is high in water supply, that there's much lower incidence of suicide. Doses of lithium orotate are significantly lower than we're used to. We're used to 900 to 1800 milligrams of lithium carbonate for our patients. Lithium orotate is more like 1 to 30 milligrams. So this can be a very useful supplement in patients with irritability, certainly patients with a family history of bipolar disorder or substance use. There is some more recent evidence that, in fact, even low doses of lithium can prevent development of dementia. That's some new research. Lithium works in many ways, but in terms of preventing dementia, it's anti-inflammatory and does promote the production of a growth factor called BDNF, which helps the brain grow and sustain itself. We use a lot of magnesium, certainly for anxiety, certainly sleep quality. Zinc. Zinc is really a very important nutrient that's necessary to break down all our carbohydrates, fat, proteins. There's some evidence that low zinc can either cause or perpetuate anorexia, and you'll find a lot of the patients, if you supplement with zinc, food can taste better and can help their digestion as well. Iron, classically we know of iron. If someone's low in iron, they have low energy, but also low iron is very present in people with restless legs. So someone's not sleeping well, you want to question about that. Why are they not sleeping? You'd be surprised if you ask enough people, like their legs may be moving, and it's definitely something we like to check for. Iron's also important in production of dopamine. So low iron can certainly exacerbate attention deficit disorder as well. And some of my favorite things for sleep, I like to use glycine, 3 grams of glycine, and certainly melatonin, 5 to 10 milligrams typically. We try and avoid more standard sleeping pills such as Ambien or benzodiazepines, just for the effects that they can cause and abuse potential. B12, I'm sure a lot of us are familiar with in terms of causing low energy, depression, and even can masquerade as dementia, certainly as people, not necessarily for our population, but as people get older, they do have difficulties absorbing B12 because of low acid production. Vitamin D, is probably, everyone knows about vitamin D now, but really probably one of the most important vitamins, really necessary as an anti-inflammatory. And without vitamin D, you can't convert tryptophan to serotonin. So, and everyone has low vitamin D. I mean, at least in the patients I see, probably the general population, but certainly in a mood disorder patient group, you're going to find almost everybody has low vitamin D. Next slide. Certainly fish oil has multiple benefits, anti-inflammatory, heart health. There is some evidence that can actually prevent a further progression of psychosis, attention deficit disorder. EPA helps the release of serotonin, and DHA makes the receptors more receptive to serotonin. One of the supplements I found actually very good, surprisingly good results with was NAC, which is a synthetic version of acetylcysteine. L-cysteine, I'm sorry, it's a synthetic version of L-cysteine. I found it very effective in patients with hair pulling or skin picking, and either 600 BID or 1200 BID. I've really found some great effects. It does work on the regulates the glutamate system, and there is some evidence for marijuana dependence in late teenagers that can help them maintain off marijuana. 5-HTP is just a serotonin precursor. And sometimes I've used this if patients don't want to go on medication. This can sometimes be a nice alternative to take a supplement as opposed to something like Zoloft or Lexapro. Next slide. I actually, this, I don't want to plug products, but Zero Plus is actually a proprietary product. I've used this a few times when generally people with OCD who don't want to take medication. It has serotonin precursors as well as a lot of the cofactors needed to produce serotonin. Inositol makes the receptors more sensitive to serotonin, and taurine helps with GABA regulation. So I do use this from time to time when someone is kind of medication hesitant. Curcumin sorbed mind is an interesting, and it doesn't have to be that, it can be any, I'm just going to call it OPCs because it's a very hard thing to pronounce. Basically, these are plant polyphenols. So these are the blue in blueberries, or the red in grapes, or the green in green tea, or the pigment of dark chocolate. These are plant compounds. I use them mainly in attention deficit. So these compounds can lower theta waves, and there's high theta waves and low beta waves in ADHD, and these compounds kind of shift the balance. They also work as antioxidants, and they also can lower copper, and high copper can also be implicated in attention deficit as well. L-theanine is present in green tea. That can increase alpha waves, which improves anxiety, concentration, and probiotics. I'm just going to mention, I mean, that's an entire lecture in itself. Certainly probiotics are anti-inflammatory, but they are, in the gut, help produce serotonin, GABA, dopamine. Next slide. Okay, and just a few things that we do here. Mindfulness, sure, a lot of us are familiar with that, can certainly help with depression, anxiety. There is some evidence that can certainly help younger adults with attention deficit. We all know the benefits of exercise. We don't all do exercise, but really important in certain, producing serotonin, endorphins for sure. Yoga, as we know, can be very helpful for depression, anxiety. And just there's one technique that came across by one of my mentors. I haven't done this or seen it done yet, but there is a breathing technique that has been found to be effective for OCD, and that's Kundalini yoga. Okay, so let's get a little bit into cases and see how we apply these principles. I'm going to present a few cases here. So this was Larry, kind of a classic case, came from a residential treatment with depression, anxiety, recent opioid use, but also a history of other drug misuse. Relatively complicated pharmacologic regimen, gabapentin for anxiety, Prozac for depression, Wellbutrin, Abilify. And still, like a lot of our clients, having residual symptoms, depression, anxiety, social anxiety, low energy, pretty standard medication side effects, drowsiness, sexual side effects, weight gain. Next slide. And here, we're kind of illustrating meeting the patient where they're at. So yeah, okay, maybe he's less depressed with Prozac, but he's complaining of sexual side effects. So to kind of ignore that is really, you want patients to know that you're hearing them and that you're willing to work with them to get them better. So we crossed over to Trintellix, which there is some evidence has less sexual side effects. He was taking gabapentin as a PRN. We made that standing. He really wanted to come off of Abilify due to weight gain and had been, I think, misdiagnosed as bipolar in the past. We tried to taper and replace this multiple times, and every time became depressed again. So ultimately, we just left it. But well, I mean, we tried at least. Did add some light therapy for seasonal depression. Certainly exercise and personal training he engaged in at the dorm. Recommended a sleep study. And then based on his history of stimulant misuse, decided to go for Strattera as a as a non-stimulant medication for ADD. Next slide. Okay, so took him a while to get labs, but ultimately he did. He had low, less than optimal B12, low vitamin D, not surprising, low folate, and low testosterone. So did some standard supplementation with B12 and vitamin D. Below that is kind of what I use as sort of a sleep cocktail, is magnesium along with the glycine, L-theanine, and melatonin, which helped. He met with a dietitian to discuss incorporating folate-rich foods into his diet, was referred to endocrinologist and was treated with testosterone cream. Certainly low testosterone can show with low energy, depression, or just, not feelings of well-being. Next slide. And, this was a very complicated case. He continued to have ongoing struggles, but part of moving him along, he ultimately got a job, was continuing to have mood issues. He had been through multiple antidepressants, and he and family were very interested in ketamine. Of course, everybody's reading about ketamine in the New York Times and elsewhere. He did get ketamine. He did have a good response. He has needed maintenance, but did have a response. He also got a new job in parks and maintenance, and is still having a lot of more quote unquote standard anxiety about his job, his finance, becoming autonomous from his parents, as opposed to, adding more medication. We talked about getting back into exercise and meditation. He had sort of swayed, strayed away from those things a little bit. Back to, seeing a dietitian for weight management. He is somewhat overweight. Certainly obesity can cause inflammation, which can lead to depression. There's definitely a dose-response relationship between sugar and other refined foods and inflammation and depression. And, overall, he still has some ups and downs, but is, maintaining a job, just secured full-time employment, and still looking at possibly returning to grad school. And do we have time for another case? Okay. So Joe, this is a little quote unquote simpler case, but nonetheless, I think is useful to illustrate some of the principles here. Came from an outpatient program, and he had major depression with psychotic features. Came on a pretty standard regimen, Lexapro, risperidone, a bunch of residual symptoms, social anxiety, some referential thinking, feeling that people were talking about him. Pretty standard medication side effects. Again, sedation, low energy. Did have some mild prolactin elevation from the risperidone. Next slide. And we did he didn't have too much long off on his basic labs, but again, as a lot of our patients, mildly low vitamin D, B12. Here's an interesting finding: low cholesterol. So standard medicine, the lower the better for cholesterol. That's not exactly true. And if you actually look at studies, it's interesting, like best all-cause mortality is actually with a cholesterol of around 240. no one, I'm not going to recommend people have a cholesterol of 240, but it's just something to keep in mind, because there's a lot of evidence that people with very low cholesterol, meaning under 160, he had 130, is associated with depression, anxiety, suicidal behavior, aggression, and even persistent substance use, especially marijuana. Also, he had a MTHFR. He was actually heterozygous, so he didn't have a full mutation, but he was partial. So we did supplement him with activated folate as well. Next slide. Okay, and this is what we did. We increased his, he was still a little bit paranoid. We increased his risperidone. Embrace was a different version that his insurance, believe it or not, would pay for, even though it's supposed to be for pregnant women. They approved that. Vitamin D and B12. Now, there actually is a cholesterol supplement, which is, I think the only one is actually called Sonic Cholesterol. I've used this a few times. Most patients and or their parents don't want to go there, no matter what you present to them, you know, because it just seems very counterintuitive to be adding cholesterol. But anyway, he deferred on that. But you know, Sonic Cholesterol is an option. In his case, he was around 130, so it probably would have recommended maybe 2 or 3 capsules daily, and then rechecking monthly until he got to around 160. You know, cholesterol is very important because it's needed for synthesis of all steroid hormones, and you know, without that, you know, your body is really deficient. Next slide. And the other things, you also need cholesterol to sensitize the serotonin receptors. So you're fighting another deficit there. So he had overall improved functioning, as we see. Still had a little bit of sedation, residual symptoms. So instead of adding more medicine, he chose to use CBT within the dorm program to target his paranoia. Ultimately returned to college, and he became, you know, he was treated with another provider once he went out of state, but his plan at the time of leaving was to try and taper his risperidone a bit due to ongoing sedation he was having. Do we have time for one more, or?
I think we should round up so we can get into some great questions.
Okay.
We can do the putting it all together.
Okay, yeah, so this was, I can summarize this patient quickly. So this patient had genetic studies which showed that she wouldn't be receptive to more standard stimulants. So we chose Strattera because she was already having fatigue from guanfacine, and clonidine could possibly exacerbate that. Again, low D and B12. We used Prozac as an SSRI because her metabolism showed that she might need higher doses of other SSRIs she tried previously. We added exercise. She was doing weekly psychotherapy. And then overall, you know, her energy improved,
that we've talked about,
decreased anxiety.
I mean,
and
you and I touched briefly on this,
return
but
to work.
I think we have to be a little bit wiggy on that, which is why we have 30 through.
I think we just need a mute,
and we compress that into one slide and put the rest in
the dorm digital. Thanks.
Okay. Yeah, so she improved focus, energy, anxiety, and then, you know, started working again. And ultimately, you know, the anxiety was at such a much better level. She chose to attend school overseas, which had always been a dream for her. And, you know, here's we go, working with the patient to help them achieve a life that they want to achieve. Okay, so I think that's all we have for our slides.
Thank you so much, Seth. There was a ton of questions coming in,
Sure.
both in the chat and also in the Q&A. And I want to try to get to all of them. That said, if we don't get to all of them, I promise that we will send an email out with some answers to the questions that we don't get to. But that was such an interesting presentation. Let's see where to start. We had one person who was curious about your thoughts on SAMe.
Yeah, I mean, There is evidence for it. I mean, I personally don't use it much because historically it's been very expensive, and some people can become agitated from it. But I mean, it can be very useful in what we call like undermethylators, and can be helpful in neurotransmitter production. So some of my colleagues who are a little more advanced or just have different favorites have used it with some success for sure. I think Richard Brown at Columbia was a big proponent of that.
Okay. Somebody actually just asked for clarification about what SAMe actually is.
Yeah, it's S-adenyl methionine, so it's a methyl donor. We say in helps in neurotransmitter production.
Got it. Another specific question. What are your thoughts about L-theanine?
I actually use it not too infrequently, mainly for ADHD patients who also have a decent component of anxiety. So, people probably who have been on stimulants and have become more anxious for various reasons, or who don't want, there are people who don't want to take stimulants for, don't want to be on controlled substances. That being said, I don't find it as robust as stimulant, but maybe in a more mild case, and it can also, as I said, part of the principle is supplementation so that you can lower doses of medication. So if you supplement with L-theanine, perhaps you can get someone on a lower dose of Concerta or Adderall, and then you're limiting overall side effect burden. So I do use it, and have had some success with it.
Great. A psychiatrist I know recommends PSIO for sleep issues. Does anyone have any experience with this and its effectiveness? The company is based in Belgium, I believe.
I'm not familiar with that product. Is it a proprietary? Is that the name of a product, or that's a supplement?
I guess so. We can, what I'll do with this is we can copy the website and then get back to the individual
That'll be
offline.
interesting. Yeah,
Yep.
I'd be interested to hear for sure.
Mm-hmm. So there's a couple of questions that are kind of similar, but in this vein. When you talk about integrative psychiatry, are you suggesting, are you sharing that supplements can potentially be used instead of medication for somebody who does not want to take medication? Or are they used in addition to medication for even more effective results?
I found, both. So sort of towards the, everything's a continuum or a spectrum. So sort of lighter end of and also depends what you uncover. Like if you found some horrendous deficits nutritionally, there are some people that can do better with, just nutritional supplementation alone. It's not the norm. I use it a lot, mainly to kind of limit overall medication burden, but and that tends to be more towards the functional medicine practitioners who kind of don't prescribe any medications. And they have success. Personally, I think we treat an overall more ill population. There's emerging evidence for things such as schizophrenia. I've never treated a schizophrenic patient with just supplements alone, or when patients have wanted to go that way, hasn't been successful. There's certainly evidence. Abraham Hoffer used very high dose niacin many years ago. There was always some concern that research was sort of quashed by big pharma. But personally, you don't do, and it's also a risk. Certainly taking someone more severely ill off medication and doing that. So my integrative is kind of the more classically integrative. We're using medication and supplements to kind of get a better overall response and minimize medicine, as opposed to, there are patients though who maybe we just have sleep issues or some anxiety or lower level ADHD that I do use just supplements, and for them, and it's fine for them.
Mm-hmm. Thank you. Somebody is asking, you seem to be presenting nutritional and vitamin supplements, exercise, and mindfulness in favor of just medication alone. This certainly seems very promising and logical. However, you haven't referenced traditional psychiatric psychoanalysis, talk therapy, perhaps because it is understood that it's already accompanying the treatment protocol. I'm interested also, however, to know your perspective on this more traditional psychoanalysis, talk therapy, and if you incorporate nonverbal therapies such as neurofeedback, EMDR, somatic experiencing, brain spotting, etc.
Yeah, so that's, I mean, it's certainly not part of this talk because it's not what I do. But that being said, I mean, everyone that I see is part of a very broad treatment program. So a lot of the patient, and so everyone I'm seeing as part of the dorm is doing, 25, sometimes 25 hours a week of, various therapies. They're doing CBT, they're doing mindfulness. I do have people who do some outside work with, somatic experiencing for trauma. So this is definitely not in place of those. I'm a big believer in therapy, was also a client for many years. So yes, that is always part of this. I mean, I think it's also, in the way that not medication alone will heal people. I don't think, the majority of people is just supplements alone. And I've actually found that to be a problem with some of the seminars and so forth. It's kind of a reductionist model that the people, you'll get a case and then people will just throw out, check this, check that, check that. And it's pretty apparent that someone has developmental issues or trauma issues or, personality issues. And no one ever mentions, you'll have one rational person says, well, how about psychotherapy for this patient? So yes, those things are essential. And I wouldn't recommend treating pretty much anyone without concomitant therapies.
And just to piggyback on that, I think what's so powerful about working with, somebody like you, Dr. Mandel, is, as you mentioned in your presentation, in order to be an impactful integrative psychiatrist, you have to be a responsive psychiatrist, and you are responsive and you collaborate with a larger team. And we are all able to put our heads together and decide, okay, not do we integrate these other therapies? Which ones do we integrate? Will this client be more responsive to something like EMDR or neurofeedback, or more of a conventional DBT group, or both? And, we can all sort of decide upon that together, but it's not just, we're not just taking sort of a one-track route towards health and wellness with the client. It's truly holistic.
Yeah, and a lot of times I'll have patients who've been through, and trauma patients are a really good example because, PTSD responds very poorly to standard medications, very, very minimal response. So sometimes they're fatigued, they don't want to try more medications, and maybe they haven't tried EMDR, and maybe their brand new patient hasn't come up yet. So we're quickly communicating and say, hey, so and so is really does not want to do all medication, which I understand because she's tried 10 and not responded. Maybe you'd want to incorporate this. And I mean, it's always a very collaborative approach, which I think is the key.
I'm seeing a question come in. Actually, there's sort of two that are in the same vein, so I'm going to ask them together. It's extremely difficult to find psychiatrists that are able to do anything other than prescribe medication in the conventional sense. Part one of the question is, how do you find that families have, responded to these techniques and to integrative psychiatrists? And then B, what do you do in the case when either the client or the family is, sort of resistant or refuses certain elements of a more integrative or holistic approach?
Sure. So families tend to go, well, two ways. Sometimes, you'll get families that they don't like medication for whatever reason. Maybe they've had personal experience in their family. Someone was on, neurolepticides, and they don't want medicine. And then, it's nice, having been trained this way, that I can talk their language, which I think is very important. So, I speak with almost every family at some point and sometimes ongoing. And when you get on the phone with them, they start thinking about, well, what about, this supplement for that? And, they're surprised when you know what they're talking about. So they're feeling heard as well. But at the same time, if someone's like, floridly psychotic and they're saying, well, why don't you just give them some, vitamin C? And, you have to be able to go with that as well and kind of present to them that maybe that's not, it may be part of the approach, but it's not the best approach for that patient. And as I said earlier, you will get people who don't want this approach. And if they don't want it, I mean, you continue to work with them, but there are some patients I have who will only take medication, and for them, that's where they start. And sometimes you can make some inroads, and sometimes if they see lab tests, they are more responsive. Sometimes if you can point out certain deficits in their functioning, they're more receptive. Or if they've had a particularly bad side effect for something that they thought was going to help them, they also might be more receptive. So this is not like, kind of a one-time thing. This is kind of an ongoing work. Like that first case I presented, that unfolded over a year. That was not like a 1 month thing. So there's these, people evolve, and, people's symptoms evolve and their lives evolve. So you need to be flexible.
Yeah. How often when you use supplements, have you been able to reduce the dosage of medications and or eliminate medications, especially if a patient is on a large cocktail of medication?
I mean, eliminate, I'd say pretty rare in this population. I mean, and that's skewed. So if you were in just like a general outpatient, otherwise well practice, it might be higher, but I think there's maybe about 10% of the patients that I see that are not on medicine and get some benefit. Certainly in terms of lowering medication, that's something that I look at regardless of any supplementation. I mean, I think people, especially if they've had repeated treatment episodes, will be, go from place to place, someone adds something and no one ever looks at taking the other thing away. And like, okay, they're better now, I don't want to touch anything. And, there's always a risk in lowering something, but we do that slowly. And even with, the first patient, we lowered Abilify slowly, no less than 3 different occasions trying to replace it, and nothing else worked for him. So it's an ongoing, you never want to say people, okay, this is the regimen and we're never going to address this again. I typically like to look at the regimen when someone's doing well, as opposed to when they're struggling. And this patient, now he has a new job, he's more stable, and he's like, hey, you know what, I'm still thinking about coming off that Abilify at some point. And it's like, okay, we'll take another look at it. And plus there's always new things coming out. The nutritional science is evolving, obviously, medication evolving as well. But this is not, it's not a static process. And, when I found there's one patients are doing better in their lives, and certainly when they've had like a large dose of, therapeutic interventions, these efforts to streamline and lower, tend to be more effective, later on in the treatment course. Thank
you. And then one quick question here, is there a directory of integrative psychiatrists? How do people find integrative psychiatrists, and especially integrative psychiatrists that work virtually, even COVID aside, in a non-COVID world?
Yeah, sure. So there's an organization, Integrative Medicine for Mental Health, IMMH, and they do, basically they do a yearly conference. They also, their founders were some of the originators of a lot of lab testing, but they do have a directory which you can search by state. Not everyone who does this kind of work is in the directory, but a large number of people are. I tend to get calls from there, from time to time. Certainly there's like, oh, we found you in the IMH directory. I'm in listservs, and someone is always like, hey, I have a patient in Denver. There's, so it can always, be found. Certainly I can always put it forward to the larger group. And it's a community, so there's people stay in contact across the United States. But I would say the IMMH directory is probably the best place to start.
Thank you. I'm going to get a couple more in before we end here. In the chat, the question is, the dorm assumes abstinence. How do you help patients and families who resist alcohol and marijuana abstinence? I'm just going to rephrase the question a little bit because the dorm is an abstinence-based model. We are striving for abstinence. So Seth, I guess, or how do you, when a client, which does happen, and or a family, how do you help them when they are resistant to not wanting to be abstinent from alcohol or marijuana?
Yeah, well, in this setting, as it has been in other settings, is, kind of go back, we do that detailed history, and then we look at the, generally, I can't imagine it's been good effects, deleterious effects that substance use. We are seeing a lot of college age individuals. Invariably, they've had problems maintaining in school, whether that started from depression, they were self-medicated, but it's become exponentially worse. A lot of these young people have become psychotic from smoking, very high potency marijuana, like daily. Often, alcohol has often led to, lost relationships, romantic relationships, family relationships, financial issues, sometimes uncontrolled gambling. So, and then there's obviously also the, the biological science about marijuana use and how it can certainly trigger and or perpetuate psychosis, make it harder to treat long term. And then, in this case, I work very closely with the dorm because that's that's the model. And, there are biological treatments for some. We use naltrexone, Vivitrol injection for alcohol and opiates. Sometimes, as I had mentioned in the presentation, I will prescribe NAC. A lot of people do swear, yes, marijuana is the only thing that works for me. And I mean, that's very rare, that's the case, especially in someone who's been psychotic on it in the past. I mean, that's like step one. They cannot be using marijuana. That's just a recipe for disaster.
And to piggyback on what Dr. Mandel has said, for the clients who are, extraordinarily resistant, while they're at the dorm, it's a community, and there is a power in the milieu and in the mutual support that takes place in the milieu. And we say to clients who tell us that they don't have a problem with alcohol or marijuana and want to be able to use that, if they don't have a problem, then that's great. And if they don't have a problem, then not using just for the period of time that they're in treatment, so that they can fully focus on developing their own skill set, and support their peers who do have a problem, should be pretty easy for them. It shouldn't be that big of a deal. And, for clients who do have a problem, that's a different story. That said, we do see some clients where medicinal marijuana is clinically appropriate, and that's a different story. But it's tricky in a multi-diagnostic treatment milieu. But what we know is that 90% of the time, alcohol and marijuana is not going to get our clients one step closer to their larger health and wellness goals. And not using it isn't going to cause harm. So, we go with that during the time period that they're with the dorm. I'm just looking, we have 3 minutes left and a couple more questions coming in, and I just want to be mindful of giving everybody time before their next meeting. So what we will do is we'll send out answers to the couple of questions that came in at the end that we didn't get a chance to address. But I just wanted to say thank you to everybody who attended, to all the questions that came in. They are amazing questions, and it made the discussion really interesting. Thank you so much to Dr. Mandel for doing this important presentation. And we look forward to coming back after the new year with more roundtable discussions. We're going to be taking a break for the rest of December, but we will have some really interesting topics to come back to in the new year that we are looking forward to presenting on. So keep your eyes open for more invitations for roundtables to come. Thank you all so much.
Thank you.
Thanks, Dr. Mandel.